Pediatric trauma. The objectives of this lecture are to note the differences between pediatric and adult trauma, note the ABC priorities in children and how resuscitation is conducted, to note specific trauma considerations in head, chest, abdominal and spinal trauma, note child abuse features and how to recognize child abuse, and finally conclusion. Pediatrics differ significantly from adults, and there's a common saying that children are not small adults, and this is to focus our attention on differences like size and shape. And children being smaller usually sustain more trauma per unit weight, and trauma will therefore have a more significant injurious effect. The surface area to weight ratio is also higher, and that results in a greater heat loss, so they are more prone to hypothermia. The skeletal differences are that the children usually have many growth centers because they're still growing, and injury to this may result in feature deformity. And the bones are also not ossified, meaning that they do not provide as much protection as they would in the adult. They also differ in psychological status. Most children do not handle stress very well, and sometimes injury might lead to regression in psychological milestones, and children are also more uncooperative in the management, and that also poses a bit of a challenge. And there are differences as well in the long-term effects. Trauma affects their future growth adversely, especially if you have epiphyseal injuries, and psychologically the impact of the trauma is much more significant than in the adult, because children are not able to handle stress very well. There are also differences in equipment sizes, because different ages require different sizes of equipment, and we must be aware of different drug dosages. And normally all this information is put together in the Brussels chart or Brussels tape, which is shown here. And this tape usually shows the height. It can be used to measure height, and because height correlates quite well with weight. But certain recent studies have shown that in some instances where this was used, it led to underinfusion, and therefore if you have the weight, it is much better to use the weight. However, this tape is quite useful because it shows the kind of the equipment sizes expected, drug dosages and other information as shown. We always start with the airway. Just like in the adult, the priorities of primary survey are the same. However, we must note that there are some significant differences between the pediatric and the adult airway. One of the differences is that there is usually a craniofacial disproportion. This means that if you hyperflex the pediatric neck as we would normally do in the adult, it leads usually to the kinking of the airway. And so normally in children, to keep the airway patent, we need just to flex the neck to the neutral position as shown in this diagram. Number 2, infants are obligate nasal breathers. It's difficult for them to breathe if there is nasal blockage, which is quite frequent because of problems with the smaller airway, and also likely to be blocked by mucous secretions or blocked by blood or edema in injuries. The larynx, there's usually an anterior caudal angle, the subcricoid narrowing. The narrowest area is below the cricoid, and usually when you intubate, the tube might go through the larynx, but especially if it's a cuffed tube, it may fail to go below subcricoid narrowing. Normally we use uncuffed tubes in pediatrics for this reason. Also, obviously the trachea is short, and so the airway is also narrow, and so the kind of tubes that are used are usually short and narrow. And usually for endotracheal tubes, a useful rule is to put a tube that is the same thickness as the little finger of the pediatric. That tends to give a good guide as to the kind of tube that we can use. Priorities in management are the same. We establish a patent airway, usually by intubation. When you intubate, we suction, we oxygenate and ventilate the patient. We must use oral airways of appropriate size. And when we do the tracheal intubation, use medication, the so-called rapid sequence intubation. Ventilation, the respiratory rate in children is usually higher, and when we ventilate the patients, we must match that ventilatory rate. And we use a smaller amp bag because the tidal volume is small, and we must be quite aware that overinflation can cause barotrauma. We must be careful to avoid that. Then in circulation, these are some of the considerations that we need to note as shown in this graph. This graph shows hemodynamic changes that occur with the blood loss, and these changes are in the heart rate, blood pressure, and cardiac output. The heart rate rises slowly with blood loss, and at about 25% blood loss, it remains the same up to around 35%. That is class 2 to class 3 shock, and then it starts to drop. This is quite unlike what you expect in an adult. And the blood pressure does not change much, but in class 3 shock, it starts to drop also, and the cardiac output will follow these two as shown in the diagram. Therefore, vital signs can be deceptive in children, may not be very useful, and of course by the time we get bradycardia and hypotension, the situation is dire, and we must act before we get to this point. Shock management follows the ATLS protocol of using crystalloids. The normal blood volume is usually about 80 ml per kg, and if you have 25% blood loss, it will result in class 2 shock already. And you can repeat this. We give it as a bolus, and we observe the effect. If this response is not satisfactory, then we can give another, we group and cross match, and we can give packed red blood cells. And when we manage shock, we must assess first the adequacy of resuscitation by assessing the vital signs, assessing the clinical state of the child, very important, that is the central nervous system response, hemodynamics response, renal response. We monitor urine output, and very important also is to monitor to assess the capillary refill and skin turgor. The urine output for the 3 pediatric age groups is as shown. In adolescents, urine output is like in an adult, 0 is the level of the adult, 0.5 mils per kg per hour. In a child that is less than 10 years old, the urine output will be 1 mil per kg per hour, and in unit 2 mils per kg per hour. So the urine output is much higher. This algorithm shows our management for the shock patient, for the stable patient in shock. That we first give 20 mils per kg of Ringer's lactate as a bolus, which we may repeat once. And if we achieve hemodynamic stability, we monitor further and we observe any indication for operation. We can send the patient for the same. In an unstable patient, we give 20 mils per kg of Ringer's lactate as a bolus, which we may repeat once. The patient may remain, if a patient remains hemodynamically unstable, we give 10 mils per kg of packed red blood cells. And the patient stabilizes, further evaluation and definitive management. If a patient is unstable, the patient requires operation. Shock management. The blood replacement usually is 10 mils per kg of packed red blood cells. That's type specific blood, or type O rhesus negative blood if we do not have type specific. And we need to warm the blood, and we need to consult the surgeon early, because such a patient will require operation. Venous access is absolutely essential in shock management, and the preferred mode venous access or infusion is peripheral line. If that fails, we can do interosseous infusion, quite useful in children and quite successful usually. But if that fails, we can also do a venous cut down. Indications for intraosseous infusion: the child must be greater than 6 years of age, and we must use an uninjured extremity, because we do not want to complicate any compartment syndrome that might occur. And besides, we would like to be able to evaluate the limb if swelling is as a result of our intraosseous infusion or trauma. And we use this if other access is unsuccessful, usually peripheral line, and the preferred site is the proximal tibia, usually below the tibial tuberosity, as shown in this diagram. We must make sure that we avoid the epiphyseal plate so that we do not cause injury to the growing plate. In shock management, hypothermia is something we must be aware of and we must prevent, because these children are prone to hypothermia more than the adult because of the greater surface area to weight ratio. And to maintain body temperature, we need to cover the children with blankets. We use overhead heaters, and we use warmed fluids and blood. And we must also prevent blood loss, because one, blood is an important medium of heat distribution, and two, loss of blood will require replacement with fluids that might not be at the same temperature. When we talk about circulation, we must also be aware that chest injuries can complicate circulation, and children are prone to blunt injury and tends to cause more severe injury because the chest wall is compliant, because the ribs do not provide as good support or protection as in the adult, because most of them are not completely ossified. And number 2, the mediastinum is quite mobile, and if you have a rib fracture in a child, then there is a greater likelihood of internal injury than in the adult, because great force is required to fracture the ribs, which usually tend to be quite compliant. Abdominal trauma: must examine the abdomen, must be aware that gastric distension can occur, take measures to empty stomach to prevent aspiration of gastric contents. Diagnostic peritoneal lavage, if indicated, should be carried out by the surgeon, and we should avoid delay. We can do CT scan, but must be sure that we do not cause undue delay management, and non-operative management should be carried out by surgeons. Head trauma: there are differences between the head trauma in children and adults. The outcome tends to be better in children than in adults, because the children tend to be more adaptive during the healing stage, but head trauma has worse prognosis for children below 3 years than those above 3 years. We must avoid secondary brain injury, and so we must protect the airway and avoid hypoxia and avoid hypotension that might cause secondary brain injury. Infants can develop hypotension from head trauma, significant bleeding into the head, and the head can expand quite significantly as well as because of open fontanelles and sutures, and so it can lead to significant loss of blood in this space. But it's also a good sign in that intracranial pressure does not increase, does not rise very rapidly as you would expect in children whose fontanelles and sutures have closed. Remember the significance of vomiting, significance of seizures, and also that increased intracranial pressure is common and should be monitored early. When we assess Glasgow Coma Scale, the VSCO chart for infants and preschoolers will differ somewhat from that of the adult because of the differences in assessment. So, for example, when a child is able to make appropriate words and behaves quite normal, social smile, is able to follow instructions, that's a score of 5. If a child cries but is consolable, it's a score of 4. If a child is persistently irritable, 3. If the child is restless and agitated, 2. And if there's no response, then we give a score of 1. And the eye opening and motor response is just as stated in the adult. Management of head trauma: we must manage the airway, breathing, circulation. Then we must refer the patient early to the appropriate specialists. We must prevent secondary brain injury, and continuous assessment is the best way to make sure that our ABCs do not deteriorate. Spinal cord injury: there are certain changes or certain injuries that are seen in the pediatric X-ray. Sometimes you get pseudo subluxation, and usually there's also a greater distance between the dens and the C1 arc. That should not be taken to mean that there is an odontoid injury. And the growth centers might mimic fractures, so you must be aware of that. Spinal cord injury without radiologic abnormality is common in pediatrics, and this is something we must always have as a high index of suspicion of. Extremity trauma management principles are the same. That is, we need to immobilize, we need to observe compartment syndrome, we need to identify nerve and vascular injuries. History is important, and growth plates are usually involved, so we need to be aware of the Salter-Harris classification and also to be on the lookout for any growth plate injuries. And blood loss is greater in children than in adults, and sometimes might result in hypotension. Then there are unique fractures, for example Salter-Harris injuries, and also green stick fractures, which you are not likely to see in the adult. Finally, we come to the topic of child abuse, and child abuse should be suspected if the history differs, the history and the degree of injury do not concur or coincide, if the patient has if there's an undue delay in seeking treatment after injury, if there's a history of repeated injury, the so-called injury-prone child might actually be an abused child, and if the parents show an inappropriate response, they are disinterested or give history that does not tally with the injury, and if history changes from one parent to another or from one guardian to another, then child abuse should be suspected. And the following are the patterns of child abuse that have been identified: multiple subdural hematomas, perioral injuries or genital or perineal injuries, long bone fractures in children who are less than 3 years of age, ruptured viscera if there is with no history of trauma, retinal hemorrhage, radiographic evidence of all fractures, and if there are bizarre injuries that are unexpected, for example, or deep burns, for example, or other injuries in areas that are unexplainable by normal mechanisms of injury. If child abuse is suspected, it must be reported, because if not, these children are usually at greater risk of death. Now, prevention of injury is absolutely essential in ATLS, and more so in when we talk about pediatric trauma, and this can be through education of parents or school programs, legislation, and good care of children to avoid exposing children to environments where they are likely to get injuries. And the physician is usually responsible, must play an advocacy role in prevention of pediatric trauma. summary, management principles of pediatric and adult trauma are the same, but there are unique anatomic and physiologic differences that we must be aware of. We need to involve the surgeon early, and injury awareness and prevention are an important part of pediatric trauma care, and we must be on the lookout for child abuse. Thank you for your attention.